Hello everyone. Today we'll be talking about how to predict new p-arterial CO2 after the ventilator changes if you have a previous ABG, and this should also help you figure out what the new pH should be. If you're in habit of getting new ABG after every ventilator changes, this lecture is for you. And let's start with an example. You just placed your patient on a ventilator and got an ABG. pH is 7.1, PaCO2 is 70. You go ahead and increase the respiratory rate to 20 and repeat an ABG. And your pH improved to 7.15, PaCO2 is now 60. Since the pH is still low, you go ahead and increase the respiratory rate further and repeated another ABG and got pH of 7.1, PaCO2 of 70. So you got multiple ABGs. Could you have done something different in this patient? Could you predict your new PaCO2 without getting a new blood gas and try to figure out underlying pathophysiology behind these changes? This carbon dioxide physiology is pretty easy to understand because it is controlled mostly by one variable, that's your alveolar ventilation. So you should be able to predict p-arterial CO2 if you know your changes in alveolar ventilation. In the previous lecture, we learned the role of end-tidal carbon dioxide measurement and monitoring in predicting p-arterial CO2. Please go ahead and review that because that might help you as well. So let's see how to approach this. One of the important things to start with is the respiratory rate that you put on the ventilator may not be the respiratory rate at which the patient is breathing. So use the respiratory rate at which the patient is breathing because that's really what's driving your alveolar ventilation. In my previous lecture, in hypercapnia, we understood that your p-arterial CO2 depends upon only two factors, your CO2 production and alveolar ventilation. Since CO2 production is usually constant, we are going to ignore that in this lecture. Let's start with our first assumption that there is no alveolar dead space. You can simplify this equation to PaCO2 equals constant by alveolar ventilation. So this patient with the rate of 15 and tidal volume 400 with pH of 7.1 and 70, you could put it in this equation and figure out the constant. First step is to figure out where you want your pH to be and then use the equation that your PaCO2 has to change by 10 to change the pH by 0.1. So in this case, we want the pH to increase from 7.10 to 7.30. So we want our PaCO2 to drop from 70 to 50. Let's say you want to get your new ABG by targeting a new respiratory rate of X. From the initial setting, you get our equation 70 equals K by 15 times 400 minus 150. 150 is your anatomical dead space. And from the second setting, you get another equation. You got two equations and two unknowns. So if you divide one by the other, you should be able to get rid of a lot of common factors, and that gives you X of 21. So if you increase your respiratory rate to 21, the new p-arterial CO2 will be 50 and your pH will be 7.30. So similarly, you can target any PaCO2 you want and calculate what respiratory rate you need to achieve that PaCO2. Remember, the assumption that we made in this is that there is no alveolar dead space. You just cannot simply keep on increasing your respiratory rate because whenever you change your respiratory rate, you encroach your expiratory time and you can start air trapping and run into different kind of problems. Let's say you set your respiratory rate to be 15 and I time of 1 second on the ventilator. Your respiratory cycle is 4 seconds, and out of this, 1 second is I time and 3 seconds is your E time. If you increase the respiratory rate to 30, your respiratory cycle drops to 2 seconds and your E time has dropped from 3 to 1 second because your I time has remained same at 1 second. To know that you're running into air trapping, look at your flow time scaler and you will see that your expiratory flows are not returning to the baseline. You can look at your capnogram and you can see that the slope of phase 2 is low, angle alpha is high, and you are unable to achieve plateau in phase 3. And finally, you can figure out magnitude of air trapping in auto PEEP by performing expiratory pause. Other way to improve your CO2 would be increasing your tidal volumes. However, understand that you need to have lung protective ventilation and you should attempt to keep your plateau less than 30 and driving pressure less than 15 when changing your tidal volumes. And the working of changing the tidal volume is pretty much similar. Instead of rate, you change the tidal volume to X, and similarly, you can figure out that your X is 500. So if you increase your tidal volume to 500 cc's, your new PaCO2 will be 50 and pH will be 7.30. So again, a word of caution when changing the tidal volume, think about barotrauma and volutrauma and lung protection strategies. So what if your patient does have an alveolar dead space? So in this case, we cannot really ignore VD by VT. So first step would be to figure out the dead space fraction. And we have talked about this in our previous lecture. Alveolar dead space fraction will be nothing but P arterial CO2 minus end-tidal CO2 by P arterial CO2. We are going to ignore the anatomical dead space as that's going to be constant in both the situation. And in this patient, we found that your VD by VT is 28%. So 1 minus VD by VT is 72%. Dead space calculation can get more complicated if you have no alveolar plateau, and we have discussed this in our previous lecture. Go ahead and review that. Plugging this into new equation, you figure out that you again get two equation, and you can simply calculate x, and your x turns out to be 21 again in this case. So if you increase your respiratory rate to 21 even in this case, your new P arterial CO2 will be 50. You have to notice one thing that we assumed again, that your VD by VT, that's your dead space, is constant and does not changes with respiratory rates. Now, if you go back to your understanding of dead space physiology, we talked about that there are two regions for alveolar dead space, one with bronchiolar obstruction, one with vascular obstruction. And air trapping gets worse with increasing rates in bronchial obstruction and not in vascular obstruction, unless you have insanely high rates. So let's look at it a little differently. Instead of figuring out our target pH, we'll say let's set our new respiratory rate at 20 and see where we end up. And our new 1 minus VD by VT is now Y. So we get another two equation, and dividing both the equation, we can remove a lot of constant terms and write X as a form of Y, which will be equal to 52.5 multiplied by your original dead space divided by Y. So pay attention here. If your VD by VT remains the same with increasing the rates, that means your Y remains at 0.72, then your P arterial CO2 will come out to be 52.5 if you increase your rate to 20. And this is usually seen in normal patient or patients with dead space from vascular obstruction. If your VD by VT worsens with increasing respiratory rate, that means your Y is going to be less than 0.72. So your PaCO2 will be more than 52.5 if you increase the respiratory rate to 20. And your new P arterial CO2 will depend upon how bad this new dead space is. This is seen in patients with obstructive lesions, for example COPD, and this is one of the reasons that your PaCO2 might not increase to your desired target when you increase the respiratory rate, because you are worsening your dead space. One of the other things that you can look at this in a different way is if you measure your PaCO2 after increasing the respiratory rate, and your PaCO2 is higher than as calculated by the above method, you possibly have a worsened dead space fraction from increasing the respiratory rates. You can pause the slide and go through the calculations again and read these two lines, as these are going to be very important. So let's look at it in a different way. We have got respiratory rate on your x-axis and your minute ventilation on your y-axis, and as you increase the respiratory rate, your minute ventilation is going to increase. And similarly, your dead space ventilation is going to increase at the same proportion, and your alveolar ventilation will increase in the same rate. And your carbon dioxide levels are going to fall because your alveolar ventilation is increasing. So if you increase the respiratory rate, you will have decreasing CO2 levels. However, in airway obstruction, with increasing the minute ventilation, your dead space ventilation can get worse, and your alveolar ventilation similarly can fall with higher respiratory rates. And your CO2 may improve initially. However, as you keep on increasing the respiratory rate, a point is going to come where your CO2 will start rising again, and that will depend upon your degree of dead space. And since patients vary in their degree of dead space ventilation, every patient is unique, and you have to figure out at what level of rate would you get the best CO2 levels. So coming back to the case, after putting the vent settings and looking at your ABG, always look at your capnogram. So looking at your capnogram, you'll find that your VD by VT is 0.8. And if you look at your flow time scaler, you see that your flow waveform is not reaching baseline. So you are possibly dealing with patient with alveolar dead space secondary to obstructive regions. Let's target our ABG to pH of 7.25 and PaCO2 to 55. And we calculate that your rate should be around 19. So we put him on the rate of 19. We again check the patient capnogram and expiratory flow limb, because we know that increasing rate can worsen dead space in this patient. And certainly we see that your flow waveform is much worse and your VD by VT is now 0.36. So our PaCO2 will not be 55, but will be much higher than 55. One of the things that you can do to make the dead space better is by giving more time for expiration. So you look at the respiratory cycle and you find out that it's 3.2 seconds now, and you're only giving 2.2 seconds for expiration. If you drop your I time to 0.6 seconds, you can increase the E time to 2.6 seconds, and you can see your flow time scaler has improved. Now you can do a couple of things after this, and you can certainly choose any one of these combinations that we talk about. First method to improve air trapping is to perform the expiratory pause, find the degree of auto peep, and try to match peep with auto peep. I have discussed this in great detail in our ventilator lectures. Feel free to go ahead and review them. Second method is to meet in the middle. Instead of 19, just increase your rate to 17. Your PaCO2 will improve, your pH will improve slightly, and you can accept that elevated PaCO2. Third method is do nothing in the first place. Keep your respiratory rate at 15. Drop your I time to 0.75 and match peep with auto peep and accept the elevated PaCO2. One of the most important thing is every patient is unique and has very different needs. Weigh the risk and benefit of your increasing your respiratory rate and accepting high carbon dioxide levels. The problem that arises with increasing respiratory rate are worsening air trapping, worsening auto peep, increased work of breathing, and risk of barotrauma. A pH of 7.20 is tolerated very well by the body. Your increased PaCO2 can come with certain complications, especially in patients with intracranial pressure issues. I have discussed the risk and benefit of elevated PaCO2 in great detail in a previous lecture. Please go ahead and review that. In summary, get a baseline blood gas, note the setting on which ABG was drawn, check your capnogram, and calculate alveolar dead space fraction. Then figure out what PaCO2 you want to achieve, and the decision is usually made to target a certain pH or some other physiological targets, and know that pH change of 0.1 is caused by 10 change of PaCO2. And you can figure out your new respiratory rates using the following two settings on the ventilator. And whenever you increase the respiratory rate, keep an eye on air trapping and auto peep. Whenever you're changing the setting on the ventilator, always try to answer these questions in your patient's context. What is the risk of high PaCO2? What is the risk of low pH? What is the risk of high tidal volumes? And what is the risk of high respiratory rates? Your goal is to make patient better and not to correct the numbers just for making them look better. One of the final comments that I would like to make that this is medicine and there are a lot of moving parts that we don't even know about. So if your patient is sick and you need a blood gas, don't shy away from it. Thank you.